Welcome to this session. There's been some really great sessions so far and some nice science discussed, and we hope to continue that. What Amy and I talked about extensively in trying to figure out how best to approach transplantation for marrow failure session is trying to go just a little bit deeper into what is going on with transplant. The key issues that we want to focus on, if you go to the next slide, please, are this. Next slide, please. The big question that we want to address is there's been a tremendous advance in transplantation approaches to aplastic anemia. And for some, we think the problem is solved. We have the issue all squared away. We know that we can do a good transplant up front, and we should do it for everybody. And I don't think we're quite there yet. And so what we want to do is look really deeply at this and ask a few key questions. And because of that, we're going to have a fun debate at the beginning about whether mud transplantation is the best, or whether we are okay with any type of transplant, especially focusing on haploidentical transplants. So we're going to look very carefully at that, and that'll be fun. Carlo Dufour and Akshay Sharma are going to represent that. What we then want to do is ask a kind of a subtle question, and that is, and we started talking about this just a little bit when we talked about the telomere workup. And the issue is this. Below that first percentile curve, if you're very far below, I think everyone would agree, you need to be really careful about making sure that your patient doesn't have a telomere disease. But what if you're between the first and the 10th percentile? Or what if you're at the 10th percentile? How much do you need to really focus on that? And the question is, what if you then do your workup and find nothing? Do you treat them exactly the same? Or if you have someone with exceptionally low telomeres, do you treat them differently? Because there are transplanters who will transplant them as if they have a telomeropathy, even if they can't find any evidence of a telomeropathy. So we want to really address that particular question head on. And then the final thing that we're really interested in is, although many people are getting used to 200 or 400 centigrade of TBI as just something you have to do, we are interested in the possibility with aplastic anemia of seeing if we can transplant without any radiation and do it safely and well. So again, that's a brief introduction to what we're aiming at, and what we will do is start with our upfront debate. Carlo, if you're ready, come down, and let's see what you have to say about what challenges remain, and does the donor still matter?
Well, good afternoon, everyone. Thank you very much, Michael. Thank you very much, Amy. It's really a pleasure, an honor for me to be here. And when I got the invitation, I was planning to have some kind of surgery, which was the result of a very forgettable soccer career in my life. And I said to the surgeon, "Guy, I have this invitation. You should make me in condition of being there." And he said, "Cross fingers." He crossed the fingers, not myself, I was the patient. And here I am. So I didn't want to miss this meeting for no reason. And the second point is that it's very challenging to try to keep, from my part, the level of the session as high as it was in the morning and in the previous one. But we take the challenge and we will try to do our best. So I am supposed to defend the no side regarding the relevance of having a different donor in the setting of transplant for aplastic anemia. And this is what we decided with Amy and Michael and Akshay, who's gonna defend the yes side. These are my disclosures, and this is basically what I will be going through, trying to illustrate the evidence supporting the no side, which is the one I have to defend. The first slide comes from different algos that you can see either from the BMT, from the British Society, from the Pediatric Hemato-Oncology Association, set the matched sibling donor transplant as a frontline treatment in anyone aged above 40. And so there's clear concordance in every algo, and this is based by the number of evidence that in children, adolescents, or in mixed population, like the study from Andrea Bacigalupo, do set survival at around 90%. But not only survival is an excellent indicator, of course, because if the patient dies, you can't do nothing. But it's not the only indicators in the modern time we have to look at for assessing that the treatment is good. So just summarize on what is the outcome in the matched sibling donor transplant studies. GVHD ranges between 10 and 20, more close to 10 rather than 20. The risk of chronic is mainly due to the previous occurrence of acute GVHD, of a cell dose, and of using peripheral blood stem cells, which is something that is still a relevant issue in this setting. Rejection is rather low, 5 to 10%, but it's still possible a long time after the transplant. That's why we suggest to keep the patients under tight monitoring for chimerism and so on for a long time. The transplant-related mortality is around 10%, and importantly, particularly on the pediatric side, the risk of secondary tumors related to the transplant is inferior to 1%, which is not the case, for instance, with combined immunosuppression. So what about the match unrelated donor? That was the first study due to the Pediatric Transplant UK group in collaboration with the BMT that retrospectively with a group of controls, so with good level of evidence but not ultra top level of evidence, show that the survival in the transplant setting from match unrelated donors was similar to that from related donors. And so was the case not only for survival, I insist on this point, but also on event-free survival, which tells us about the quality of the survivors. Low rate of GVHD, which is, as we know, something we really don't want in aplastic anemia because we don't have leukemic cells to fight, but simply avoiding disturbances to the patients, was rather low and of a low grade. That was confirmed in a subsequent larger size EBMT study, still retrospective, in which where you see the survival was again around 90%, but the graft versus host-free, rejection-free survival, back to the indicators of the survival, was at the good level of 86%. What about the adult setting? This is a study from Andrea Bacigalupo that probably is going to be shown also by Akshay, that shows that there's a clear impact of the age in the match unrelated donor transplant, with patients aged above 40 having a far inferior outcome as compared to those aged at younger level. But also comorbidity have an importance. This comes from the King's group. It shows that patients who have 2 or more comorbidities tend to have a significantly inferior outcome as compared with those who do not have. But there are a number of buts. There are studies, and again coming from King's, stating that the outcome in terms of survival between unrelated donors and matched sibling donors is not significantly different. And the same study from Andrea Bacigalupo that showed that high-risk patients do bad if you are transplanted from MUD, show that if the patients are intermediate low risk, have a similar outcome in terms of survival, whether are transplanted from a matched sibling or a match unrelated donor. And importantly, if you look at age group, which is particularly at risk for complication, and this is a study from CIBMT-RABMT, about 500 patients, you see that people in the age of above 50, you may not have significant difference as for the survival between related and non-related donors. What about the upload now? I mean, this is the first study from EMI that was based on patients refractory to immunosuppression with the classical PTCY scheme that she consolidated afterwards, including a little bit of irradiation. The bottom line of this story was that all the patients were alive with a limited amount of GVHD, with no viral reactivation, and with no clonal evolution, meaning not necessarily as bad clonal evolution as correctly Neil pointed out. I mean, a clone is not necessarily a bad clone, as group of cells coming from the same mother, basically. What did I do? Right, okay. And then the EBMT came afterward. Pedro Prata was the PI of this study, who showed that in a little larger cohort, mostly pre-treated with the heterogeneity, the limits of the retrospective study, the survival was in the range of 70-something, But when the cohort was split between those patients who had the Baltimore conditioning regimen versus those who did not have, well, there was a clear advantage in terms of survival, 93% for the Baltimore group versus the 64% of the non-Baltimore group. This is the last study that Amy and her group published. It's about 27 patients with a median age of 25, but have a look at the composition of the cohort. A large majority of the patients was aged above 40, with I think 44% of patients which were above 40 and 36 above 50, meaning that 2/3 of the cohort was higher as compared to the age threshold that is reckoned as dangerous for those who have the transplant in aplastic anemia. So the recovery was pretty fast, and the survival at 1 to 3 years was set at 92%. There were some deaths in a limited percentage of patients due to viral reactivation in marrow failure, which led Hami's group to increase the irradiation from 200 centigrade to 400 centigrade, with important positive impact on the survival. You see that. All patients who had that conditioning regimen survived, but also in graft-free survival, which is an equivalent of the qualitative indicator, where all patients did not have this kind of problem. If you look more carefully at the GVHD rate, acute GVHD rate and chronic GVHD rate were low in terms of occurrence and also in terms of severity. Other important side effects were the infections, most grade 2, most due to viral reactivation. These are the studies. But you know that in the pyramid of the level of evidence, on top are supposed to be meta-analysis, which should include all the studies around and put together in a kind of mixture that should sort out more complete results. We have two meta-analyses regarding the topic I have to discuss. One comes from the BMT and compares alternative donors versus immunosuppressions. Alternative donors are mainly, but not exclusively, haplo-transplant. And this meta-analysis suggests that there is an increased rate of events in negative events in patients receiving immunosuppression and in those who had the transplant as a rescue. As I said, meta-analyses are supposed to be on the top of the level of evidence, but indeed there can be some flaws. And flaws here are the fact that this population was basically composed by pediatric patients, which we know are those who do well, and mostly were Asian, and there were very limited data on the elderly side. However, the conclusion of that study was that it's probably better to have the alternative donor transplant in frontline rather than rescue, and this is the important message. The overall survival tend to approach that from matched sibling donor and match unrelated donor. There was another meta-analysis, most recent, which more focusedly compare match unrelated, match sibling, and haplo from a Chinese group. This meta-analysis indicates that haplo versus MUD is worse as for acute, chronic, GVHD, CMV, and 5-year overall survival. But when it comes to compare haplo versus MUD, it was no different as for survival and failure-free survival, and even better as compared to GVHD. Limitation of this meta-analysis is related to the fact that this is made mainly by Chinese populations, so East Asian patients. There is no good separation for age, and the conditioning are so heterogeneous, and so are the source of cells that huge heterogeneity really diminishes the value of the meta-analysis. Anyway, what we can take is that there is haplo poses himself as a reasonable option in those patients who do not have match-related donor in frontline. So this is what basically I was able to find as particularly appealing in the literature, and that's what's my take-home message. The match-unrelated donor outcome equals that of matched sibling donor now is established in young patients, and it can be possible the case also in some category of adults, particularly young at low risk. I outlined that there are reports, those from King's, that suggest that there can be an equal outcome in matched sibling donor and in match-unrelated donor, even in the elderly. Recipient age and recipient comorbidity are still important factors independently of the nature of the donor that has to be taken in account. So we cannot reduce all to the type of donor, but also have to be to have a little more focused view. The haplo, the outcomes, and we have seen not only for survival, but also for other indicators from the graft-free, rejection-free survival, are similar and tend to match a related donor and tend to be close to match sibling donor. And this is also occurring in the young, as the study from Amy showed. Of course, that might be a center effect, because if this comes from the Baltimore centers where transplants have been performed for so many years with good results, that's not the same as doing transplant from haplo donors in a center that does not haplo transplant very frequently. So the center effect has to be taken somehow in account. Anyway, haplo remains an appealing option to be considered. Maybe the ongoing study comparing haplo frontline with the match can contribute further to locate haplo correctly in the algo. Finally, trying to give my answer related to the question of the talk, whether the donor still matters. Well, based on the evidence I have shown you, and based also on what is my personal idea, I think that in recent years, there's clear evidence that the relevance of the donor has been reducing as compared to past years. So I wouldn't say it doesn't really matter at all, because there's no such complete evidence, but the tendency is clear to reduce the importance of the donor, which is good for the patient, because that means they will have many more choices for their own transplants. That's the next slide. I mean, BMT has generated a lot of the data I have shown you today. Regis, Antonio, Austin, Andrea, Pedro, a number of people. My friends now, originally they were colleagues, but now they are friends. Philip, Rodrigo, Neil, and other people with whom we work in tight contact. My mentor, Lucio Luzzato, and of course the colleagues and the friends of our hospital at the Gaslini unit in Genova, that you can see really overlooks the Mediterranean Sea. That's all.
Akshay is next, and he is online, I believe. There you are. Akshay, can you hear us?
I can hear you. Can you hear me and see my screen?
We can. It looks great. Go for it.
Perfect. Well, thank you, Dr. DeZern and Pulsifer, for giving me this opportunity. Unfortunately, I couldn't be there in person today due to some personal commitments, but I'll hope to give a spirited response to Carlo's presentation. And when we asked the question, I would say absolutely yes, the donor still matters. These are my conflicts of interest disclosures. None of these are relevant to the presentation today, but just like Carlo, I will be showing a lot of Kaplan-Meier curves in the next few slides. So let's start with the standard treatment algorithm for severe aplastic anemia. If you have a matched sibling donor available and you're young, you straight away proceed to the matched sibling donor transplant. If you're older than 40 years of age, you first receive IST, and if it doesn't work after 3 months, you receive a matched sibling donor transplant. On the other hand, if you do not have a matched sibling donor, under the current algorithm, everybody receives IST first. And if you are less than 60 years of age and you don't have a response at 3 months, you can either receive a matched unrelated donor transplant, alternative donor transplant, or a second IST course. If you're older than 60, you straight up goes to the second IST, except if you're less than 20 years of age and you have very severe aplastic anemia, you go to a matched unrelated donor transplant. Now, the reason I'm showing you this thing is because there are two very important factors over here, and that's the patient age and availability of donors, which determine what pathway will you choose. And this is based on our data from several studies that have been performed over the last few decades, looking at the impact of immunosuppressive therapy. As you look over here, what you will notice is with many of these different regimens shown on the left-hand side, the response rate has been about 60 to 70%. And even amongst the patients who have a response to IST, about 1/3 will relapse with their disease, and still some patients will continue to have clonal evolution and will develop MDS or leukemia. And so because of this reason, even though IST tends to work in a number of patients, it does not work in everybody. And when it does work, there's always that risk of relapse. Transplantation is and shall remain relevant to patients with aplastic anemia. So now the important determinants of outcomes after transplantation are listed over here, and I'll talk about these in the next few slides one by one. Let's start first with the age effect. So as Carlo just mentioned, this data has been first shown in CIBMTR on the left and a more contemporary cohort on the right from the EBMT. As you can see, patient age matters a lot. Younger patients who are less than 20 years of age have about a 86% overall survival rate after transplantation. And as you get older, patients older than 40 years of age have about a 53% overall survival long term. Carlo showed this data comparing mud transplants to matched sibling donor transplants, and I would I look at that same data and I see something else. So I completely agree with Carlo that the outcomes after upfront matched unrelated and matched sibling donor transplant overall survival and event-free survival over here are very similar. And when you compare matched unrelated donor transplant upfront to IST, while the overall survival looks similar as in the top right corner, the event-free survival is very different. So many of these patients who get IST, they have a recurrence of their disease and then they end up getting transplanted and do fine. What I would like to point out over here is that the median age of these patients in Carlo's study was just 8 years old, and all of these were younger than 20 years. And so with this data, I think what we can safely say is that upfront matched unrelated donor transplant has similar outcomes to matched SIBs and superior event-free survival than IST in young patients. Unfortunately, this is not true as Carlo just mentioned, in older patients. So when we have older patients who are receiving matched unrelated donor transplant, as shown in this EBMT data, the overall survival over time with age goes down to 49% in those who are over 40 years. And then in a more contemporary cohort combining data from CIBMTR and EBMT, similar results have been seen in patients who are older than 50 years of age. And so once again, while the data on how good mud transplants are is looking comparable to matched SIB transplants in younger patients, that's not unfortunately true for some of our older patients, perhaps because of accumulation of comorbidities in older individuals. What about donor age? So the Japanese looked at that. They looked at transplants where patients had received transplant from a young donor less than 39 years of age or older donors over 40 years of age. And clearly, they saw a benefit of using younger donors. So younger donors have better outcomes in terms of better survival. Older donors have higher infection rates, higher graft rejection, and acute GVHD shown over here. And so whenever possible, we'd like to pick a younger donor over an older donor for our patients for aplastic anemia. When we are talking about donor age, obviously we have to focus on donor HLA typing, which I think is also very, very important. And so on the left-hand side, this is data from the CIBMTR cohort looking at all non-malignant diseases. And it clearly shows that fully matched unrelated donors, 8 out of 8 matched, have superior outcomes than 7 out of 8, and they have superior outcomes than 6 out of 8 matched. The Japanese did a similar study only looking at the aplastic anemia cohort. And once again, the complete match are have much superior overall survival than those who have one or more mismatches. And this is primarily because with progressive HLA mismatch, the outcomes get worsened due to graft failure and acute GVHD that's associated with greater mismatch. When we look at the cord blood transplants, the EBMT showed many years ago in 2011 that the size of the cord, the cell dose matters, and greater than 3.910 to the 7 TNC was better. And so they did another study in young patients shown over here in the middle, and the results were published in Blood in 2018. So if they only took greater than 4 times 10 to the 7 nucleated cells with a Flu-Cy ATG regimen, the outcomes were quite good, around 80%. And the same data was then replicated in a Japanese cohort shown over here. And so adequate cell dose, especially in younger patients, as you can see over here, it's definitely associated with good outcomes in patients receiving unrelated cord blood for aplastic anemia. The EBMT also looked at haplotransplants, which Carlo just showed. Again, the overall survival was 78%, but when you divide that into pediatric patients and adult patients, as you can see, pediatric younger patients did much better than older patients, where the overall survival dropped to about 69%. When they divided it between the Baltimore regimen and the non-Baltimore regimens, anything else, clearly, Baltimore regimen was quite superior with much better outcomes. And the adverse outcomes that were seen in these cohort receiving haplotransplants was basically because of the GVHD risk, both acute as well as chronic GVHD. So let's focus now on the haploidentical regimen, the Baltimore regimen. Dr. DeZern has presented this data several times before, and I'll quickly point out one thing. In the relapse refractory cohort, in their hands at Hopkins, the outcomes were very good. 100% overall survival. In the treatment naive cohort, it was a little bit low, but still pretty good. Because of these excellent outcomes, at least the Hopkins group felt quite comfortable that by increasing the TBI dose to about 400 centigrade, they were able to move this regimen into the upfront setting. And with that upfront protocol at Baltimore, these outcomes have been excellent. Very low acute GVHD, very low chronic GVHD. But when the same regimen was taken and converted into and tried in a multi-center trial in BMT CTN 1502, the overall survival dropped to about 80% with a graft failure-free, GVHD-free survival about 77%. The rate of acute and chronic GVHD went up to about 16 and 26% respectively, which is quite different from the experience that we have seen in Hopkins. Now, these outcomes that I'm showing over here from 1502, the confidence intervals did overlap from the single center study, but I think one point that Carlo also made, and I'll just reiterate over here, is experience matters a lot. If you have done, as a center, have done way more transplants, you have developed the expertise of how to do these transplants well. And that, I think, matters a lot more than what donor we are using, at least in some aspects. And this is just one more example of highlighting that. So we all have been taught that bone marrow graft is better than a peripheral blood-derived graft because it reduces GVHD. And when there was a combined cohort from CIBMTR in Japan that looked at more than 2,000 transplants that were done, what they saw was clearly in US and Canada, in other high-income countries, as well as other upper middle-income countries, that trend was clearly seen. So bone marrow performed better than peripheral blood. But in low-income countries that were able to perform transplants, the outcomes were flipped. Peripheral blood-derived grafts did much better than bone marrow-derived grafts. And the reason for that was, in this setting at least, the risk of graft failure and infections was much higher. And so the faster you were able to get the graft in, the faster you had immune recovery, the better the outcomes were. And so the center effect definitely is very prominent when we are looking at transplantation and cannot be completely ignored. And so to conclude, I'll say that just like Carlo agreed, age and fitness of the patient matters a lot. Younger patients have good outcomes. Outcomes of older patients are improving, but they're not quite comparable to those from younger patients. And for that reason, MUDs may be a good alternative for transplantation, but those approaches still have to be developed a little bit better. Donor age certainly matters, and wherever possible, we should prioritize younger adult-sized donors over older donors. And then alternative donor outcomes are improving, and it does require a little bit of more finesse and experience to perform these transplants efficiently. And so in the end, I would close by saying that the donor does still matter. I agree with a lot of things that Carlo has said. I think this is not a black and white answer, but there's a lot to think about. And I think all these factors need to be considered while making the best donor choice for a patient. And with that, I thank you for your attention.
So we better not ask questions now because that would take the entire rest of the period. But we do have something, and I failed to mention this, a really important take that we wanted to really have, and Staci Arnold from Emory School of Medicine is going to represent that. what are the implications of the treatments we give? Because as we're getting better with transplantation and doing a lot more upfront transplantation, we have to understand what the long-term side effects are. And so Staci's going to address that.
Well, thank you, everyone, and thank you to the conference organizers and session organizers for this invitation. I also want to thank my colleagues, Dr. Sharma and Dufour, for doing a little bit of this discussion in advance, so hopefully that will save me and you all some time. It looks like, though, this slides maybe aren't exactly the right ones are in the right order. But in essence, if there were the slides there, you would see the survival curves that we've already well presented, so I don't need to discuss, the role of donors in transplantation for aplastic anemia. But what I will say is that when we're having this discussion of treatment strategies for aplastic anemia and looking at transplantation versus immunosuppressive therapies, one of the key things to point out when we talk about events, as Dr. Dufour highlighted, is that individuals who are transplanted do better than IST with respect to transfusion dependency and therefore iron overload, as well as clonal development of clonal disorders. But we have to compare that in contrast to the big unique side effect of transplantation, which is secondary malignancy, which certainly can be impacted by the development of graft versus host disease. So if the slides were there, you would see a lovely pie chart of, and maybe Yara has them, but yeah, probably my beautiful pictures were a Mac to PC issue, yeah, because I don't see the first couple slides. But again, we're over time, so I'll keep talking, and I'll show them to you at dinner if you want. But there was actually a single institution study that showed a higher rate of malignancy after transplant at 13%. The bulk of those were squamous cell carcinomas, and the vast majority of those were associated with chronic GVHD, as many of us would expect. After that, there was thyroid malignancy. I'm doing all this from memory, so if I misname some of them, hepatocellular carcinoma, largely associated with hepatitis C, and various other cancers, including breast cancer, metastatic cervical cancer, and I'm sure I'm forgetting some. But I think that's an important thing to state because, again, with transplantation, that's a unique risk that we're not seeing. So now when we get to this slide about do we change the longstanding algorithm that we've all been shown about our approach to managing aplastic anemia, I think we need to not only take these outcomes and survival into context, but also look at late effects. So now if we can go to slide 4, we're on track. Thank you. And so what I regret, though, is that the bulk of the information we have on late effects is not specific to transplantation, not only for non-malignant disease, but aplastic anemia. So the bulk of what I will present to you is all comers, which of course is skewed by the fact that there may have been prior treatment impacting these outcomes. However, I will include some data of a recent experience that specifically looked at children and young adults who were transplanted for non-malignant disease. So when we talk about musculoskeletal late effects, the largest and most known is related to avascular necrosis, of which we know corticosteroids are a significant and probably the largest causative factor there. The overall reports indicated about 10% avascular necrosis, and in the specific pediatric cohort, though, it was much lower at 2%. Also, we have seen osteoporosis. That is also associated not only with steroids, but with the use of total body irradiation, which I'm seeing on the image there, but you're not seeing up there, so I just need to stop using a Mac and just cross back over. The last, and I think important, certainly when you're talking about a pediatric cohort, is growth disturbance. And that this report showed up to 7% growth disturbance, which really is impacted with all of the agents you use in your conditioning regimen. So that's corticosteroids, TBI, cyclosporin, and even methotrexate. Oh, no, different slide. And so next we'll talk about sort of head, eyes, ears, nose, and throat late effects. And in particular, I think the one that's most commonly seen and discussed is cataracts. And unlike many of the other late effects that either stabilize or decrease over time, cataracts actually can increase over time from transplant. This particular study showed a very wide range, but up to 80%, and most associated with the use of TBI. Again, fortunately, it's far lower in the pediatric cohort when you're transplanted in that age group. And of course, in addition to be associated with TBI, it's also associated with the use of corticosteroids. Now, next, when we talk about keratoconjunctivitis or Sicca syndrome, that's a challenging late effect to discuss because it's somewhat of a chicken or egg. You can see Sicca syndrome with GVHD, and certainly the treatment of that can also continue to manifest some of these symptoms. But these data showed that 20% overall had Sicca syndrome, and then when you incorporate chronic GVHD, that number actually doubled. Next, in terms of stroke and seizures, about 10% actually had those. And again here, is that a direct effect of the TBI, or is it more what we see in terms of press and side effects of your cyclosporin or other calcineurin inhibitor uses? And I think the last is quite important to discuss, especially again when we're talking about transplanting children, is the neurocognitive impact. But even adults, I think, care about the cognitive impact of transplantation, and a 20% of incidence of memory problems is quite notable. And again, that can be seen with all of your agents, including methotrexate, which is known to have neurotoxicity. Now when we talk about cardiopulmonary outcomes, again, we're fortunate here that the cardiovascular outcomes are quite limited, with less than 1% having congestive heart failure and none having myocardial infarction. And this, of course, is associated with TBI, but also, which is not showing up here, iron overload. Fortunately, though, in a transplant cohort, the iron overload that's having a cardiac effect should be quite limited. But it's important to know that as we're considering transplant in the context of IST, which your transfusion burden may actually be quite higher. There's up to a 40% impact of airway or parenchymal lung disease, and that can be restrictive or obstructive. Fortunately, the restrictive lung disease can be reversible, but the obstructive is not. And when we talk about obstructive, that also can be impacted by your GVHD, which most often is the obliterative bronchiolitis that we see. And so next, I think one of the complications we all think about with transplantation and know that is a significant factor is the renal complications. And we do our best to avoid nephrotoxic agents. But even with that, we see almost 10% renal failure. And there is some newer evidence looking at pharmacokinetics as well as sorry, things are changing. So as well as other late nephrotoxicities that suggest that what we originally thought as the cyclosporin-associated nephrotoxicity was reversible and ended with cessation actually does persist in some individuals and can become a chronic factor. So that's also something important to consider. And then last, I think another one of the toxicities that does, again, unfortunately increase over time, although I will say diabetes is the one endocrinologic late effect that actually does not increase over time, and usually, since it's corticosteroid associated, can actually reverse or end with cessation. But these endocrine side effects, I think, are very important to be aware of and can be quite challenging to manage. 5% can develop diabetes. Others with hypothyroidism actually have subclinical hypothyroidism up to 15%, which is why many of our transplant surveillance guidelines recommend screening for thyroid dysfunction. Fortunately, again, this is lower in children, but still nonetheless is adversely impacted by all of the the agents that we're using in transplantation. And again, I'll highlight iron overload as another potential factor that's at play when we're talking about the endocrinologic late effects. And that also gets to the one that I think families, and in particular parents when we're transplanting children, care about the most, and that's fertility. So there is a 3 to 6% pediatric incidence of gonadal dysfunction, which I think we would consider that low for most studies. However, when you're talking about fertility impact in a child, that's quite high. Some studies specifically looking at aplastic anemia have showed over a quarter actually are able to conceive among both men and women. And whether or not those conceptions go on to actual pregnancies actually does reduce with 5% in the males and 12% in females in that study. And again here, just listing the causative agents, which I should have mentioned in the beginning, and I think we all know, is of course dose dependent. So some of these factors may or may not occur based on the dose or amount of these agents, and can be either primary or secondary as a result. Now, one other thing I do want to highlight here in the discussion of fertility is some work that our group has done, and this is actually a study looking at sickle cell disease. But we've done a lot of work in the field of transplant to try and reduce the toxicity and have these reduced intensity and lower toxicity regimens. However, what we learned in looking at our sickle cell patient population is that when you look at the cumulative cyclophosphamide equivalent dosing, actually some of these RIC and reduced toxicity regimens have higher CED equivalents than some of the myeloablative. And so is this convention that we're using to estimate risk actually more for myelosuppression and immune reconstitution and not actually telling us about end organ toxicity, because our patients were actually having diminished ovarian reserve and impaired fertility with these reduced intensity regimens. So last but not least, I did want to highlight the one study that had some evidence specifically looking at late effects in aplastic anemia, and just highlighting here that this group in particular found that it was largely the thyroid function disorder that was the most prominent and of concern. And even those receiving cyclophosphamide actually had normal growth, development, and even normal pregnancies. They also, I think importantly, showed that quality of life in these pediatric transplanted individuals was actually comparable to controls, and their only evidence of challenges in that area were with health insurance and life insurance. And so then that leads to hopefully something that will help us settle these debates that we're having about the role of upfront unrelated donor transplantation in aplastic anemia is the TRANSIT trial, which is randomizing IST to unrelated donor transplant using traditional IST regimen with cyclosporin and ATG. Although I will mention that although the steroids used are not treatment, they are used to mitigate serum sickness, and certainly in those who have side effects can get longer courses that may be impactful. And then it's a flu-cy, ATG, and TBI-based conditioning regimen with cyclosporin and methotrexate as GVHD prophylaxis. But importantly, what we're doing, and I did have prettier slides that I changed, but is also looking at secondary objectives of health-related quality of life, as well as looking at gonadal markers of infertility, which, again, we hope will color the discussion and advance the field in terms of the role of unrelated donor transplant for aplastic anemia. And we are not going to have questions right now.
So for the second half of our session, we'll revisit some of what we talked about this morning. We talked a lot about telomeres and aplastic anemia and diagnostics, and we have our second debate between Dr. Kristin Schratz and Dr. Suneet Agarwal to talk about how we might approach some of these patients more clinically, which draws on some of the nice points made about what's too long to wait, how do we figure it out, and we're looking forward to the science.
Okay. Thank you, Amy and Michael, for the invitation. I'm excited to continue our telomere discussion. We had a lively discussion this morning that touched on some of the indications for telomere length testing. My focus in this part of the session is more on interpretation of telomere length, and then Suneet will share data from his transplant trial of short and shortish patients. And how do we advance? Okay. So the only validated test to measure telomere length for medical decision-making in the clinic is flow cytometry and FISH assay, or FlowFish. And it's a technically demanding assay because of the controls needed and the need to work with live cells. So there's limited numbers of labs worldwide that do this test, but it is very important in certain scenarios. And data from our group, from Mary Armanios and Amy and others, have shown that telomere length measurement impacts management decisions in an important subset of patients with aplastic anemia and other idiopathic bone marrow failure. Identification of short telomeres is an indication for genetic testing if not done already. And we'll get to this sort of a little bit later, but who do you test? But in those with very short telomeres, that is an indication for genetic testing. And then if you identify a bona fide short telomere syndrome, that has many implications for treatment in terms of avoiding immune suppression, donor selection, your transplant approach, anticipating and screening for extramatopoietic complications, the lung and the liver disease, and then family counseling. But not all people with short telomeres have a short telomere syndrome. And so we'll explore some of that with a few cases and some background. So there's a well-defined normal range of telomere length in the human population, as seen here by the upper and lower boundaries on these curves. Telomere defects unite a group of pediatric and adult disorders into a single syndrome complex and has a predictable and well-defined natural history that is driven by age and the severity of the telomere length defect, meaning how far below the median are you. And it's key to understand this to both recognize and manage these patients across the age spectrum. If you address one problem, you have to anticipate the other problems may inevitably occur over time. And at its most severe, you have 2 to 3 or all 4 of these systems filling at one time. And so how do you manage that? And the aplastic anemia that we see in these short telomere syndromes is a slowly progressive disease in contrast to the acute onset immune-mediated aplastic anemia. And the risk for MDS and AML increases over time, with most patients diagnosed after the age of 50. So there is no single telomere length threshold that is diagnostic of a short telomere syndrome, with many caveats. So this figure reflects 226 patients with diagnosed short telomere syndromes that are molecularly, genetically, clinically confirmed diagnoses that we've cared for at Johns Hopkins. You can see the different genes and the number that are unknown. With increasing age, you can see there are less patients below the first percentile. And above the age of 60, certainly, most overlap with the normal curve. And so this is some of the diagnostic challenges in this space. And although initially the first percentile was thought to be a cutoff, there is no single telomere length cutoff that one can use in isolation. You have to take the whole clinical picture into account and integrate the age, the presentation, the family history, and the genetics at times in order to interpret these results. There is a robust negative predictive value of long telomere length. So in our cohort, no one had telomere length above the 50th percentile. These are all mutation carriers. So having long telomeres, you can be confident that you're not in this space. But there are plenty of patients with true short telomere syndromes who have telomere length between the first and the 50th percentile, and then there are a number of patients who appear very short who do not have short telomere syndromes. So I'm going to now give a few examples and cases to highlight some of the caveats to telomere length measurement and nuances to interpretation. I'll show the limitations of when there is a clonal process in the blood, cases of secondary attrition due to proliferation, and non-telomere inherited causes that can have short or shortish telomere length. So this example is a 70-year-old male with familial pulmonary fibrosis in telomere length between the 1st and 10th percentile. He was identified to have a TERT mutation. He underwent lung transplant for progressive lung disease, and about 2 years post-transplant had acute worsening of his chronic thrombocytopenia. He was now transfusion dependent and had other lineages affected. We repeated his telomere length in the setting of this new pancytopenia, which showed an acquired shortening in the granulocyte lineage only. Subsequent bone marrow biopsy done in the following couple of months showed that he now had a hypercellular marrow in contrast to the prior hypo, and a new monosomy 7 clone. We looked at a cohort as a whole, so these are all patients with short telomere syndromes, all adults. We looked at this lymphocyte granulocyte concordance across our cohort and compared those with short telomere syndromes without MDS to those with MDS or AML, and found that those who were MDS-free, the lymphs and the grans, this is on your left side, were concordant. But in those who had this clonal myeloid disease, MDS or AML, on average had shorter granulocyte telomere length. And this is not unique to the short telomere syndromes. Any myeloid clonal process can cause this. So you have to interpret telomere length in both lineages or all lineages. And so that's really helpful for us to be aware of. So this also can happen in the lymphoid lineage. So this acquired attrition can happen in lymphs as well. So this is a 49-year-old gentleman with CLL and history of CLL and T-cell lymphoma in his father, found to have a germline pot1 mutation. Telomere measurement was done for variant interpretation purposes. Is this pot1 pathogenic? We see in the granulocytes that he has a very long telomere length above the 99th percentile. However, in lymphs, initially, this was read out as having very short telomeres. And so there was initially this puzzling, but then when we looked at the flow plots, we could distinguish two separate populations in the lymphoid cells. There was the predominant CLL clone that was very short, but you could see his constitutional long telomere clone there as well. So again, caveats to interpreting this test if you have a clonal process in the blood. And at its most extreme, this is the case of a 30-year-old with de novo complex karyotype AML with short telomeres. And so the prior cases, they were more hypoplastic MDS, AML, or CLL. We could still distinguish two populations. In this case, it's a packed marrow de novo AML, and we cannot distinguish different populations. And so you see both lineages appear to be exceptionally short. But this is a false positive. The flow plots for this patient appeared atypical, which reflected likely the circulating leukemia cells. And another red flag was that this length fell below the threshold we typically see. So there is a threshold of short that we typically see when looking at patients that you just don't reach in a normal individual. And so these cells fell below that typical threshold, suggesting again this is not a normal constitutional clone. And so clinically, we would not be able to interpret or sign out this report. We'd have to say, please send us a remission sample, or if there is a high suspicion, just do your genetic testing and don't wait for this result. So those are some more extreme cases of clonal diseases in the blood. Now I'll shift back to the bone marrow failure space, a non-malignant space. So this is a 10-year-old with history of recurrent sinopulmonary infections and postnatal growth delay, short stature, microcephaly, concern for, and also had immunodeficiency and bone marrow failure, concern for an inherited bone marrow failure syndrome. Laboratory evaluation showed pancytopenia, showed hypogammaglobulinemia, B-cell lymphopenia, and then you see the telomere length here. Telomere length below the first percentile lymphocytes and near the first percentile in granulocytes. Now in a young child with symptomatic bone marrow failure, this pattern is actually atypical for a true short telomere syndrome. The lymphocyte telomere length is not quite short enough, and the granulocytes overlapping with normal are atypical. So this pattern would, for us, raise flags as being something non-telomere. And so genetic testing was done and identified biallelic mutations in the LAG4 gene in this patient, consistent with the LAG4 deficiency, which is a different natural history, a different disease. And strikingly, the asymptomatic sibling, who did have some mild B-cell lymphopenia, but really asymptomatic, had strikingly short telomeres. That does overlap with what we see in our patient population. So this, you have to have the clinical context and the genetics here to distinguish these. And then the final case is a 4-year-old preschooler with macrocytosis and thrombocytopenia, a very typical presentation, potentially for short telomeres, but non-specific. Had this telomere length concordant in lymphocytes and granulocytes, reasonably short, but his genetic testing showed a mutation in SAMD9. So again, a very distinct natural history from the short telomere syndromes. And so Fabian showed this figure earlier. And so the goals of these cases were to illustrate the nuances of telomere length interpretation and to show that the first percentile threshold is not specific to short telomere patients. I've circled on this figure the cases of non-primary telomere disorders who can present with short-ish telomere length. And the mechanisms of this shortening are unknown, and not all patients with these genetic diseases have short telomeres. There's a lot of heterogeneity, but it can happen. The short telomere may reflect an acquired attrition related to the increased cell turnover because of increased cell death, or potentially some interaction with telomere maintenance. We don't understand, but importantly, it is a distinct natural history and a distinct genetic disease that you need to be aware of. And so to summarize this, so telomere length interpretation is dependent on the clinical context. There are several bone marrow failure and immunodeficiency syndromes with telomere length patterns that overlap with the short telomere syndromes. And the clinical presentation and genetic diagnosis may distinguish them. And then in the setting of overt hematologic malignancy with significant clonal burden, flowfish may appear to be false positive and cannot be reliable. And so I don't know that I answered all of those questions, but certainly when do we need to do a full genetic workup? Anybody below the first percentile, because of these nuances, really needs genetic testing, and you can't always distinguish otherwise. And Suneet will talk to us more about the treatment and how to incorporate this into treatment.
Dr. Agarwal is coming down. You know, maybe we've talked about how donor does matter, doesn't matter. We want to make sure we have the approach correctly, but we don't want to limit somebody if their telomeres aren't truly short, but we might have a good regimen if they are.
Great. All right, thanks so much to Mike and Amy for inviting me. And this isn't as much of a debate, but how do you make something like this useful when you have a test that's emerging and basically might portend a functional problem? It actually kind of concerns you about how to actually operationalize it. And this is really mainly a story about that. So the question is, what can we learn from the telomere diseases and severe aplastic anemia? And the take-home messages I want to convey to you are the following, is that trying to use this information about flowfish telomere length testing and the emerging genetics of telomere diseases. More than a decade ago, we designed a minimal intensity bone marrow transplant protocol. And it was designed for dyskeratosis congenita and to solve the poor outcomes in those patients. But we've shown, I think, that it works in patients who have marrow failure and severe aplastic anemia and very short telomere length. And the reason we have a hint in that direction is because we gain these insights by basing the study on a biological marker and adhering to the prospectively defined eligibility criteria, and not picking and choosing patients based on what we could try to see in their history, but saying we've defined these criteria, now let's see what happens with these patients too. So the problem that we were trying to solve is this one. And in several retrospective studies, on the left from Barbara and Betty, and then on the right, the EBMT, EWOG, MDS, and University of Minnesota, as many of you know, a very high upfront mortality historically from transplants for patients diagnosed with dyskeratosis congenita. This at least had a lot to do with conditioning toxicity, exposure to radiation and alkylating agents, and the overlap of the pathology of DC with the target tissues and BMT toxicity. And in several patients, the comorbidities that they come up with limit their eligibility for BMT. And you'll notice also, and I'll point out later too, a high graft failure rate, not just about toxicity, but real complications in the management of these patients. So in 2012, we asked the question, can we eliminate radiation and alkylating agents entirely from the transplant for patients with marrow failure and improve outcomes? And the regimen is shown here, and I won't dwell so much on the study parts of it, but only a nuance of something that I actually decided to analyze for this talk specifically, and that was patients who are unidentified versus unidentified for telomere biology disorder. So the regimen was alemtuzumab and fludarabine, bone marrow grafts only, cyclosporin and mycophenolate for patients with marrow failure. And the rationale was that the telomere defect in the hematopoietic and immune cells of patients with DC will result in a replicative disadvantage, and there'll be a competitive advantage for transplanted cells. And that eliminating the alkylator and radiation exposure should improve outcomes because those things are actually compounding complications and underlying comorbidities in the patients. And that, accepting that we wouldn't get it entirely correctly, what's the rate at which you can salvage patients if you actually have graft rejection with this minimal toxicity regimen up front, and this becomes important. So these are the inclusion and exclusion criteria, and again, I won't go through all of them, but this is pediatric to adult age range, ultimately marrow failure, not other manifestations with a significant cytopenia or transfusion dependence, and this is the key. What we decided to do in 2012 with incomplete genetics and a functional test is define the inclusion criteria to be a clinical syndrome or a known pathogenic gene mutation or lymphocyte length, telomere length less than the first percentile by flow fish. And that was very important. We allowed a lot of donors, we allowed a lot of comorbidities, and excluded MDS and AML, and that's critical too for the interpretation of this. So these are the clinical features of the 40 subjects that were treated on the protocol between 2012 and 2023. You can see all of them have very short telomere length. The age range is 20 months old to 51 years old, with 11 patients who are over 18 years of age. And there's genetic and phenotypic diversity, and usually we accept this because there's some unidentified causes, but in this talk specifically, this is the key. There's unidentified at the time of transplant, 11 patients out of the cohort of 40, but we proceeded anyway. Most of them were unrelated donors. It may be of interest, mainly matched, several mismatched unrelated donors. So this is the primary engraftment rate, and forgive me for not updating the slide. It looks pretty much the same if you have 40 patients, but this is the 35 patients that were treated, and all of them except one engrafted, and that lack of engraftment by day 42 was due to hypersplenism, and the spleen was taken out and the patient engrafted without needing a second allotransplant. So this is the key. What about the durability of engraftment? So we had sustained myeloid engraftment in 32 of the 40 patients. We did see graft rejection. Stereotypically, a graft rejection in 7 patients that was within 3 months afterwards, and those patients were salvaged, were identified and salvaged successfully, and one had autologous reconstitution. And there was one secondary graft failure due to a concurrence of viral infections that caused pancytopenia and then a fatal mucor infection. So again, what's this patient population composed of? These graft rejections, how are they represented in terms of the unidentified versus identified? We'll get to that in a second. But this is the overall survival of the cohort, and an unfair comparison to a historical cohort of dyskeratosis congenita transplanted patients. But the point is well made, that essentially there's a reasonably high survival out of 5 years out, 85%. 3 had early treatment-related mortality. So these are transplant-related mortality. These were all infections in these patients, 2 to 6 months, and the rest are of the mortality in this cohort is dyskeratosis congenita or underlying TBD related, and I'll show you that as well. So I did a subgroup analysis just for this talk. I've been interested in doing it, and so it's not formally done, it's just done by me. But the point is that out of these 8 patients who rejected, who were they? So patients with a known telomere biology disorder, genetically proven, 4 out of 29 rejected their graft. And out of the other known BMF, ultimately, severe aplastic anemia or unknown, 4 out of 11 rejected. So that's not significant, but this is a very small n. But more importantly, what happened to them? So after they actually rejected, or they were all salvaged, I already told you that. But of the other BMF, we had no mortality in those patients. All the mortality is in the DC cohort as well, in the known TBD cohort, I should say. So now some vignettes of who these other patients were and where we started to get this hint. And in the beginning, it was very concerning. How should we handle our protocol? But the 6th patient who was treated on this protocol after we had success with the first 5 was a previously healthy teen diagnosed with severe aplastic anemia, no syndromic features, not fully worked up, no family history, treated with immunosuppressive therapy at an outside center. He then relapsed and had an inherited marrow failure workup done. Did not show any causative genes, but lymphocyte telomere lengths now, confounded, right, by prior therapy perhaps, were less than the first percentile, just along the line. And the pre-BMT marrow cellularity, people ask me this all the time, was 40%, so it's considerable. So what's his diagnosis? You have a concern for a telomere biology disorder, but not really proof. And this isn't really fitting the picture entirely. But he was eligible for the protocol, and this was the first point in which we actually made a decision to say, you're eligible for an open protocol. We're not going to pick and choose. We're going to counsel the patients carefully about what we know and what we don't know, and treat accordingly. And so the family chose to proceed with a 10 out of 10 unrelated donor transplant, and the patient's engrafted and doing well 8 years out. The second one is a syndromic patient, but it probably is because of a different disorder. So this patient presented with truncus arteriosus, transpose repair, multiple abnormalities due to a contiguous gene deletion, which definitely included the MECOM gene, and that gene is right next to TERK, and we don't know if TERK was really affected. It wasn't genetically absent, but it could have been dysregulated. So for the cardiac repair, had a thymectomy as a neonate, had progressive marrow failure over the course of the first decade of life. BMT was declined and deferred at local centers because of his heart disease, and his lymphocyte telomere length was very low, and he had a negative DC gene panel. So What's his diagnosis? Probably MECOM-related marrow failure. But he was eligible for the protocol as well. And even his lymphocyte telomere length could be confounded, as Kristin was saying, by his thymectomy. Are other things impacting his lymphoid disorder? But his hematopoietic system has very low lymphocyte telomere length. That much we know. So they chose to proceed with a mismatch unrelated donor transplant on the alemtuzumab fludarabine protocol, and he's done well and is doing all 6 years out as well. And then finally, this is not one in which we don't know the diagnosis. It's quite clear clinically what happened to this patient. So he's a previously healthy 4-year-old with sudden onset jaundice, severe hepatitis, and a normal CBC. And so there's no etiology uncovered, and he's responding to steroids. No other etiology, let's say. And we learned from the great work of Dasha and Tim and their group about the fact that you can have very low lymphocyte telomere length in this setting. And his were indeed less than the first percentile, negative DC gene testing, and the picture just didn't fit clinically. But again, amongst his options, this protocol was now open. Now he's the 18th patient. We say you could do immunosuppressive therapy, you can engage on the trans-IT trial, you could proceed with this protocol if you wish, your choice. And so he had a mismatch unrelated donor transplant, and he did very well 5 years out. He has really solid counts. And what's really interesting, though, you can see his chimerism starting to mix a little bit, too. So it's interesting to see what's going to happen with him. I don't really think it portends graft failure. It may just be that he doesn't need the transplanted cells as much as he has his own cells at this stage. We'll see. So anyway, the conclusion is alemtuzumab and fludarabine is an effective conditioning strategy for BMF in patients with DC or very short lymphocyte telomere length. And the questions that this raises: is this a favorable approach for any marrow failure, severe aplastic anemia with very low lymphocyte telomere length, despite the caveats and what we've heard before, even when the suspicion of telomere disease is low, and we have a starting population that tries to address this, and it's not unreasonable in my mind to study that. The question is, should alemtuzumab fludarabine be trialed in other marrow failure and severe aplastic anemia disorders with shortish telomeres, especially getting into the adult range, or regardless of telomere length? And this seems very odd. One would say we already know the answer to this question. It's not enough intensity. But the question I would have for you is, what is the appropriate threshold for accepting upfront toxicity in an entire group of patients when you have a high rate of salvage for BMT, if you can propose that for some proportion of them you could spare them exposure to agents that cause toxicity and infertility, especially in the pediatric population? So that's one of the assumptions to challenge. So, and just acknowledge the people who participate in the study. Thanks.
And not to be confused, but we have another Dr. Agarwal who will give us a talk also eliminating some of the components of conditioning, in this case TBI, for alternative donors. Thank you.
I am hoping that not everybody is so tired hearing these great talks this morning. And PSAs. Suneet and I are colleagues, but not related. Anyway, I am very excited to be here, and I really appreciate the invitation from the organizing committee for presentation on this novel strategy in patients with Fanconi anemia, where I hope we will be able to see some data in the TBI-free conditioning regimen and think about other bone marrow failure disorders and what we can do about it. So we have great outcomes in Fanconi anemia over the years. Past 20 years, we've seen the outcomes for patients with Fanconi anemia who needed a transplant with a matched sibling donor or an alternative donor. They have done really well. And here is the alternative donor graph looking similar to sibling donor, but these alternative donors are unrelated or cord blood. That's where we are. So with that, I would like to let you know where is the field and where we would like to push it. And I'm only talking about Fanconi anemia in this session. So we are relying upon NMDP as a cord blood for the unrelated donor pool. We must really do some efforts to expand this donor pool because every child, every patient who needs a transplant needs to have a donor. 2, the T-cell depletion techniques have been very effective in reducing graft versus host disease, but they lead to increased viral infections, delayed immune reconstitution, and such And so how about the techniques of T cell depletion with the subset depletion only that will still decrease the rate of GVHD, but give you better reconstitution? And thirdly, the most important question, can we eliminate total body radiation or low-dose busulfan in patients with Fanconi anemia with an alternative approach using a monoclonal antibody? I'm going to do the donor choice first, easy thing first. So you know this very well. So even with the matched sibling donors and over 30 million unrelated donors in the registry, we have a significant number of patients who still need a donor, especially the minorities. And here, if we can develop approach to use a haplodonor, which is either a mom or a dad or a sibling in our pediatric setting who are half matched, and we can manipulate the graft to get rid of the alloreactive alpha beta T cells and keep the NK and the gamma delta T cells for immune reconstitution, we may have a viable option where we can have a donor for every child who needs a transplant. So for this technique, we have a protocol at our center at Stanford, but a lot of data has come from Rome initially, where a megadose CD34 graft was prepared for early engraftment. The TCR alpha beta T cells were were removed to eliminate the GVHD and preserve the gamma delta T cells. So these are the haploidentical grafts, but the conditioning is with the TBI 200, modified cyclophosphamide, fludarabine, ATG. So that is an issue. I actually included this slide to just show you in Fanconi anemia. Today, the standard of care is the sibling donor transplants do not have any need for radiation. We can do without it with fludarabine, Cytoxan, and ATG. The unrelated donor transplants definitely are needing 200, 300, depending on the center of TBI. And there was a short report from Minnesota when they tried to de-escalate this TBI, there were graft failures under 150. In the haplo setting, I don't know, maybe there is a report existing of a TBI-free regimen, but I'm not so sure of that. So again, all this time, TBI or low-dose busulfan, we are hearing, contributing to genotoxicity. Blanche really published that paper, which was very remarkable. So I'm going to go directly. So if not TBI, what could we do? And here I'll talk about the anti-CD117 antibody, which has changed its name, and I'll be calling it briquilimab because it's currently listed as briquilimab. So this antibody is against c-KIT receptor. The c-KIT receptor binds to the SCF, and the binding leads to stem cell proliferation, differentiation, and actually survival of HSCs. And when we have the c-KIT antibody, that reaction is stopped, the stem cell niches are emptied, and the space is available for the stem cells to home, whether they are donor stem cells or gene-corrected stem cells. Now, all this work on the antibody, the preclinical work has come from Stanford from a couple of different groups, and the first clinical trial using this antibody in SCID babies was also led by us. So now what we did was we actually decided to use these two complementary strategies. We are using the antibody in the conditioning to replace the radiation, and we are using a TCR alpha beta depleted graft. Antibody to make it safer out of genotoxicity possibly, graft to have a better engraftment, increasing the donor pool, but what we have introduced also a very close monitoring of the PK levels of the immunosuppression, ATG, fludarabine, antibody, so we can understand the niche clearance and level of immune suppression. So that data would be available soon. This trial is open. We have currently enrolled. I'll show you the enrollment. We have treated 6 patients, 7th is in workup, and 8th patient is lined up. So the trial is accruing really well. And here is the treatment schema. Top portion is the donor preparation, collection of cells, and then processing in the processing facility. The graft is prepared fresh. But look at the bottom portion where the patient is prepared or the conditioning is given. the antibody is given as one fixed dose of 0.6 milligram per kilogram on day -12, followed by immune ablation. So the immune ablation is ATG, fludarabine, and a dose of cyclophosphamide. There is no radiation and or busulfan, and there is no post-transplant immunosuppression required. So no methotrexate, no mycophenolate, no calcineurin inhibitor, because we have the T cell depletion. So that's great. Simple inclusion criteria, Fanconi anemia, progressive marrow failure, and such. This is the enrollment I told you. I am now going to show you first the antibody clearance. So the briquilimab antibody clears in a very predictable and steady manner. Everybody cleared the antibody before transplant. So that's one thing I wanted to say, that the antibody is very predictable in its clearance and steady. I'm going to show you the data in the two cohorts. In fact, we have 6 treated patients on the antibody conditioning and 6 treated patients on the TBI-based conditioning, and I hope the data will show you something. The first is patient demographics, of course, all young patients with bone marrow failure, and the grafts are coming from their parents or siblings. And this is the same cohort on the TBI-based conditioning. I just wanted to make sure that you were able to see the initial demographics. Now, looking at the graphs, so when you look at the graphs for the antibody conditioning, we wanted to see if we can make these graphs in a very reliable and consistent manner. Yes, we have a great dose of CD34 positive cells. Yes, the graphs are depleted with the alpha beta T cells. And look at the engraftment. All patients, all 6 patients have engrafted with neutrophils and platelets in 2 weeks. Their last platelet or blood transfusion was in the first week of transplant and none thereafter. So that's great. Well, the TBI-based conditioning also is the same. So I'll give you a minute to look at this data. Because no matter what you use TBI or you use the antibody, engraftment is the same. And the grafts are very consistent. Chimerisms. So the donor chimerisms in all 6 patients, they came back very early. So the first chimerism we do at 2 weeks upon engraftment, and then at 1 month, and then frequently thereafter. The graft came in, the chimerisms were steady, and they remained durable. The very first patient on the trial is 2 years out and keeping solid 100% chimerism at this point. So this is very early engraftment with a very durable graft, and the TBI-based conditioning is the same. It's a little bit longer follow-up in the first 2 patients. It is the same. So there is really no difference. The regimen-related toxicity, mucositis alone, no veno-occlusive disease. Some viral infections needed a short course of antivirals, and very little GVHD in the haplo setting, only 1 patient with chronic GVHD of the skin got very well maintained, doing great. Very similar data with the TBI-based conditioning. So I am trying to show you that if I remove the TBI and use the antibody, it looks pretty much same. Mucositis only, no veno-occlusive disease of liver, and the incidence of GVHD isn't going up any. And this is the haplo setting, so keep that in mind. So I am going to just put a conclusion here. Yes, of course, our lab can do a great job in manufacturing the grafts. Yes, of course, the antibody is tolerated extremely well. It's safe, no side effects. Yes, we have the robust chimerisms and which are durable without the total body irradiation. And I would say that this data is early. We have to finish enrollment of all 12 patients, but by the looks of it, I could say there is an evidence or early evidence that it's promising data to remove TBI from the conditioning regimens for Fanconi anemia. So overall, we feel that this combined approach is able to do all 3 objectives that we set out to do, increasing the donor pool, decreasing the graft versus host disease, and possibly removing TBI from the regimen. So this is where we are currently in the field. I'm going to come to this slide later in the question section, but I would like to acknowledge everybody who has participated in the trial, and our collaborators. Marcin has been great, and I have another collaborator in Kaiser Southern California. So this is wonderful. I could go back to this previous slide and leave it here, because I have had many questions about this, how this antibody would work and how not, but we can discuss that in the questions. I'm good to say here.
Well, those are some fantastic talks. We'll skip the summary slides for the sake of time and open it up to questions for the audience. Go ahead. Just go down the line. Dr. Young.
Yeah, so this is sort of a more general question, but perhaps to the speaker on the line. So what is the center effect? I mean, when you generalize the protocol, you're not sending it out to podunk. I mean, these are centers that have seen viral infections and know about graft rejection and deal with these same drugs. So is that, I mean, is it a mystery? Is it patient selection? Is it the way the data are analyzed? Or is it something we really don't understand? And I have a second question to follow that.
Akshay, I'm going to put you on the spot to answer first.
No, thank you for that question. So one of the things that we do know in the 1502 trial was that when bone marrow was being harvested, the way we harvest bone marrow is different at different institutions. And that matters because the cell dose that comes out is different based on your experience with bone marrow harvest. So those individuals who got above a certain number of CD34 cells in their bone marrow had better outcomes than those who didn't. And that was one of the things why the outcomes were so different when we looked at Hopkins only results versus multi-center results. And Dr. DeZern might actually know what that number was. In addition to that, I think there is also something to be said about the comfort level with a regimen. If you have been doing a certain kind of transplant with a certain kind of regimen for a very long time, you learn how to anticipate what happens with that regimen, what happens to those patients, and you can preemptively do things. Sometimes we do it unknowingly. Sometimes our SOPs change in certain ways that we are doing things, anticipating and preventing them from happening just because we are so comfortable doing a particular recipe. And so these two things are what I was referring to when I was talking about the center effect.
Carlo, what do you think?
Sorry. Neil, I mean, to me, it's something similar to what Akshay said. I mean, for instance, we have a committed team for infections anticipation and treatment, which is something that does not occur in any transplant center, even the larger ones. So that of course justifies the rate of infection, which is far lower in centers like ours or yours or others. And that's it. I don't think it's related to the way data are produced or generated. I think more is related to practice, basically, to being accustomed to understand what's going to happen, to anticipate problems, or to deal them with this increased expertise. So this is my personal view in this respect.
And a tiny thing to add to that is most protocols, if the PIs are paying close attention, they see these things at centers and educate them. And Amy's protocol, when you found the cell dose issue, Amy wrote a beautiful intervention that took care of the problem.
Good. I have a second question.
If I can just add one thing to your question. I do think there's this intangible that we aren't capturing in terms of the social determinants of health that are impacting outcomes. And so there may be a patient side thing in terms of access to care, centers that are able to follow their patients more closely to the transplant center, and all of those are impacting, especially when we talk about haplo, the rates of GVHD and those sort of outcomes.
The second question, also maybe one or two of you will answer, is how worried are you really about the 400 dose? I mean, if it's something we don't really care about because after all it's not high enough, then why are we trying to get rid of it? And what would you anticipate long term? I mean, it's a criticism for the immunosuppression, right? We heard it this morning. We really don't know long term, even though we're out 5 years and even though cytogenetic abnormalities tend to occur early, but we have to wait long term. but what's the long term for 400 centigrade?
I'm happy to answer, and I'll be honest, I am worried, and I think clinical investigation to find ways to do better with less always makes sense in human beings. And I think this really is why we asked Dr. Arnold to cover some of her points. The hardest clinical discussions I have are with a currently fertile female who is still in her childbearing years and very much wants a family. It is very hard for me to concretely tell her that 400 would maintain her fertility. But I'm open to others' comments.
You said exactly what I would. I think the 400 matters when we talk about late effects, and across the board, TBI was the biggest influence in late effects.
Yeah.
And one thing to add, Neil, is an interesting thing is that the 400 matters, but it actually matters even more for males, where people with a single dose of 400 have a very high chance of permanent azoospermia. And females get a little bit more, and you can have a little bit more cyclophosphamide. I mean, I think you know this better than I do, but it can affect it definitely. So the lower the better.
Okay, appreciate it. I have one third question. Sorry, I don't want me to dominate. I know
Okay,
it's late.
I omit my comments so you can make your third question.
Yes, my third question is, Suneet, I'd really like to hear that graft rejection, you can manage it. And I think, how we balance risk is important. And as a representative of the immunosuppression community and the validity of that, I do have to point out, and as we've recently published with CIBMTR, patients who survive Bavisha, Emma, correct me, 1 or 2 years after immunosuppression have normal life expectancy. So even if immunosuppression isn't perfect, let's say it only works in 50% of people, hitting everybody with what is potentially 400 centigrade other risks, I mean, I think there is some consideration for what, in a perfect world, let's say, would be the right sequence, especially since we have some very good indicators for the really feared late consequence of immunosuppression, which is not relapse, generally can be managed, and you can transplant at that point, but high-risk cytogenetic evolution. We have a pretty good way of, with genomics, to predict who's going to go that route and get them to transplant earlier. It's not a transplant versus immunosuppression. I think, for me, it's the sequence and really a more careful, for all of us, more careful balancing of where the risks are for individual patients.
Is there a data indicating the length of immunosuppression, the agents used for, and the late effects?
No.
So,
No.
Neil, thank you for advertising the transit trial. That's really nice.
So, no, sorry. I agree, Neil. If I can comment to your view, I mean, so that may be good for. You said that if someone survives 1 to 2 years after immunosuppression, is in condition of running a normal life for the rest of his or her life. Yeah, but that may be. I'm sure this is the case for adults, but for children, if you take, the curves after 20, 25, 15 years follow-up, 1 out of 4 still maintains the response, and this is something that.
But that's children.
Yeah, that's children. No, I'm speaking of children. And so that's something that I'm also scared a little bit of the 400. But rather than having, I would take the risk of the 400 rather than having the risk knowing that in 10 years' time, this guy, 1 in 4, will have a crab marrow failure, basically.
So just a comment and 2 questions. The first one is, despite what we published with Antonio, you know that I'm a transplanter, so I have to disclose this. And I can tell you that I'm really worried also for the 4-grade TBIs. We have just been published in GCO this year, but Mary Eapen, these high rates of secondary cancer in sickle cell disease patients who were transplanted exactly the same 15 years ago. And we know that if you're not proceeding to 4-grade, then we go for graft rejection. So we have to find something else. But anyway, this is a comment.
I just
this
want
is
to
not
comment
doubtful.
on that.
Yeah.
I worry about the marrow failure community drawing tons of extrapolations from the sickle cell community, even though it's the same
because
regimen because of the hydrea.
There is hydrea and so on, of course. But anyway.
When you don't eliminate your marrow in sickle cell disease, if you have partial chimerism.
Yeah, but then we saw Staci coming. We saw Staci coming with endocrine dysfunctions, fertility, cardiovascular events. Sorry. So we have to make some progress on that side, and we all agree on this. Now the question is for Suneet, because we are using this conditioning regimen for telomere disease in our center, and I should confess that we were not so successful. So we are mainly adults patients, so I was asking on the age on your cohort. And the other thing that we were experiencing very severe chronic graft-versus-host disease. So you didn't show any data on graft-versus-host disease, so if you could just answer on this, and just, yeah.
Sure, what was your first question? You were
The
saying
first-
something about high dose?
No, this was a comment that we were discussing all together. No, the chronic graft-versus-host disease in your cohort of patients and the median age of the patients.
The median age of the patients, we could get it from the dots that are on that list. I'm sure that it's, so if 11 or above 18, then we're going to talk
Yeah,
about
because
something
we are
like
more
that.
an adult, so
Sure,
it might
sure, it'll be
probably.
higher. So in the chronic, so acute GVHD, I think 5 or 6 patients got acute GVHD, all steroid responsive. And then there were
No chronic.
a similar number of chronic GVHD.
Yeah.
Not all of them are managed. None of them have chronic GVHD as a long-term consequence too. So I will have to ask you some of the nuances of like what the patients were, what you did, et cetera, et cetera.
You know, because we were using the same things, we're trying to publish this study. It's only 20 patients. It's a nightmare to publish it because obviously it's horrible. It's more easy to publish our race trial. So we were really facing this, and at the moment we are really asking ourselves to continue to transplant those patients, even with match-unrelated donors. That's the reason why I was asking the
I
question.
just want to be clear. So you have used no alkylator and no radiation.
Yeah, it was FCC, Marrow, as source of
No,
stem
FCC is
cells.
very different than what I just described.
Yeah, it's true that there was one dose of alkylating agent. There was one dose.
So that's a completely different story. When we salvaged patients and gave them any dose of alkylator, they developed GVHD.
Even with 40 milligram per kilo. Okay, so we'll try. The last one. I love your transit trial. So could you please elaborate a little bit in 30 seconds to present it? And the last thing, I was amazed the way you were keeping control, smiling, while your slides were not appearing at all. I think a round of applause.
Well, thank you for that. But I can't say it's my transit trial. Dr. Pulsifer is one of the co-PIs on the study. Mike, if you correct me if I say anything at all wrong, but ultimately the transit trial is a randomization of IST versus upfront unrelated donor transplant. It does allow mismatch in well-matched unrelated donors. But in essence, looking at the primary outcomes of survival, response to treatment, and then secondary outcomes of clonal evolution, health-related quality of life, and gonadal function. It's largely for the traditional sort of children and young adult cohort. I think we max it
25.
25.
Up to 25.
25
But since it's
and
mainly
260.
pediatric centers, it's really going to be 21 and below, almost all.
So more or less on the same line, I mean, concern about the 4-gray TBI, I think we still have gaps, and we may improve our conditioning regimens. And while we moved from fludarabine and Campat alone, or with a little bit of cyclophosphamide, then TBI, so we know that timing is crucial. I mean, the lesson of the post-transplant cyclophosphamide is very informative. Maybe if you had, I could even imagine that if you have a patient with an haplo donor, you may have fludarabine and Campat, and then you may add cyclophosphamide on top of that later on, because this may also affect the recipient immune system. So it's just to speculate, because I really believe that this community may generate some further trial to investigate, novel conditioning regimens, and the FCC platform and DeZern platform, I believe, are two very robust regimens that could still be improved to do better for our patients.
Can I comment on that just for a second? So are you saying haplo with post-transplant Cy for severe plastic anemia, or for telomere diseases? What are you referring to?
Well, I was thinking to both. Of course, they could be different. I mean, of course, for severe plastic anemia, we were more robust data. With telomere disease, we don't want to give alkylators. Well, fully agree. This is the same with Fanconi. You are aware of the data from Brazil using Campat on top of that. So,
I think one thing to just, it doesn't matter if the Cy is before or after. The problem with the patients who have telomere disease is that they're actually going to have a lot of toxicity from that, and the whole point is to avoid it entirely. So even to Neil's point, like, it isn't about upfront and 400 centigrade of TBI. The point is to have none of it, because then you actually don't incur the toxicity and you actually salvage. So FCC and what I showed are not the same thing.
I know.
The moment you add cyclophosphamide, like, I think that's where this is getting a little bit confused.
No,
The point is to not actually.
Then I was switching to the severe plastic anemia.
Right.
Well, and if I'll add, I think I hopefully made an argument that we should push towards removing TBI from any regimen, but certainly amongst those with DNA repair defects.
I've got a couple of comments, and I want to, being a student of Neil, second what you said. But I mean, first of all, again, we are trying to contrast these two, particularly immunosuppression. But the issue at hand is really that when I think about the last 3 patients that I lost, all were patients who underwent unsuccessful transplant. I mean, the mortality of patients treated with immunosuppression, even if they don't respond, is negligible currently. I mean, it's very low. Yet, even if we are conservative and say, yes, the treatment-related mortality is 5%, fair? Yeah. I mean, take a revolver with 100 bullets, put 5 bullets everywhere and roll and do this.
But
you
I
will
have to
see
say-
that.
We understand your point.
But the person you're going to send to transplant is going to be really sick.
No, okay, so.
Gary, please, you know that I'm a transplanter. You can stop with shooting us.
No. But the other thing is that and to the true diseases that are genetically related, to this congenital and so on, and we have short telomeres in aplastic anemia, irrespective whether they are mutations or not. So the important issue would be that the short telomeres are important, but not in bone marrow, right? Because if the short telomeres in the bone marrow were important, right, then Amy, with her regimen, would not have almost 100%, right? She would require you mentioned that the patient with Shortish Telomeres without even genetic thing might benefit from the special regimen, yet she achieves 100% survival, right?
Her regimen is more intense than the one I described, so why would you say that the logic doesn't flow, right? So my regimen is basically it could be the other way around.
Her regimen is more intense.
Yeah.
Yet we know that some of these patients with aplastic anemia who were transplanted definitely had short telomeres, right? Just by definition, irrespective whether they had telomeropathies. So the issue would be the testing for the telomere disease, not for telomere length, right? Because this is the body of the patient who is not transplanted, right? You don't transplant stroma, you don't transplant these things.
I think the point I'm trying to make is that you choose to expose everybody to it. You think of it still as oncology. You choose to expose everybody to a set of agents that you know are going to incur toxicity when some proportion of them may not need to be exposed to that to achieve a successful effect. And I think that the field needs to understand that the non-malignant is not like the malignant, and you should think about it a little bit differently. And the patients get to decide that too, if you're sitting there in front of them talking about.
So I'd like to wrap this up since we're only 35 minutes.
More question.
Okay, one more question and then we're done.
Real
wait
quick.
a second, and one comment.
Well, I have a real quick question for Rajni, actually, since you set it up. I think somebody has to ask it. You can't argue with outstanding empiric data suggesting that the Jasper antibody works very well to replace TBI. But I've always been confused in this setting of what is your c-Kit antibody hitting? Because Fanconi patients already have an ablated marrow for the most part. There aren't stem and progenitor cells. Are there T cell populations? What is it that it's hitting?
This is a question I've been asked a lot, and that's why I had that last slide prepared, because a c-Kit antibody basically, so the cellularity in these patients is not less than 5%. It's 5 to 30 or 40%. So there are some progenitors. Now what we know of the antibody, it really is working on the niche, so clearing the stem cell, whether or not it's only a myeloablative. It has no immunosuppressive element to it. Whether it clears with it, the stem cell parts for all the T cells and others, I can't answer that, but it definitely, when we have the preclinical data, it depletes the CD34 positive, 117 positive cells in a very remarkable fashion. Now, I have to say, we in this trial are in a very difficult spot. You know why? If we show these results, people say, why do you need the antibody? And we here on the other end are sitting on, because the 2 graft failures, as we learned in Rome on this particular TBI-based alpha beta protocol, were in patients who did not receive TBI. And so it does something. So then I was thinking about it. What could be the possible mechanism for the antibody? So there is a paper from Jude, who is one of the main scientists on this discovery and preclinical work of the antibody along with Anishka. She published a paper in Blood on synergistic action of the antibody with TBI 200 and azacitidine, and that was the basis of an adult trial with the antibody, with the use of the antibody with 200 in elderly patients who couldn't tolerate. So I was thinking, and I asked Judy if there could be a series of experiments done to see the antibody synergizes with either cyclophosphamide or fludarabine. I really can't answer that today, but it does definitely do niche clearance for whatever cells are there, and it's synergizing with something. I don't have the heart to remove the antibody and try just immunosuppression alone because of the 2 failures.
Thank you. I think we're done. Right, we're done. Thank you very much. Need to move on to the next. Thank you so much.